For session 7 of Foundations in Global Health, we're going to talk about health sector governance and financing at the country level. Throughout this course, we've talked first about the burden of disease and talked about the epidemiologic and demographic transitions that will occur within the global population. We covered human rights and ethics and the definition of what health is as defined by the World Health Organization. We have also covered global health governance, discussing UN agencies, non state actors, including non governmental organizations, NGOs, business corporations, and foundations. And we've also talked about global health financing and have even stratified it by providers of that financing, governments, private foundations, and business and corporations. We've also talked about managers or organizations that manage that financing, which include bilateral organizations, global health partnerships, NGOs, business corporation sector. And we talked about organizations that spend that specific funds to achieve certain outcomes, including global health partnerships and partners, governments and low and middle income countries, civil service organizations, CSOs, NGOs, UN organizations, and several other organizations. The last in this series of talks are what we're going to talk about is country level financing, which basically will conclude sort of this talk about global health, health financing, and finally, country level financing. When we discuss country level financing, we need to discuss first mortality. So, mortality in this graph is from 2000 to 2030, so over a 30-year lifespan. So, as we can see, over the next 30 years, mortality or deaths due to non communicable diseases on this graph, cancers, ischemic heart disease, and stroke, are going to be significantly more compared to communicable diseases, malaria, tuberculosis, HIV/AIDS. So, over the next 30 years or so, there's going to be considerably more mortality. And this holds true for mortality in high income countries and low and middle income countries. So, over the next 30 years, global health financing, no matter if you're in the low and middle income countries, or high income countries, mortality is going to be due to non communicable diseases per as it compared to communicable diseases. Although the previous graph has shown that mortality is going to be due to non communicable disease, cancer, heart disease, etc., this graph shows the percentage of development and health aid or trends and their allocation. And this is from the Institute of Health Metrics. And you can find this data here. So as we can see, programming in terms of billions of dollars spent, and here's billions, here's 20 billion, here's 40 billion in terms of expenditure, 1990 to 2019. You can see that programming is still on communicable or infectious disease. Here is HIV/AIDS, here's child and newborn health, reproductive matters, malaria, tuberculosis, other infectious diseases. So you have other infectious diseases, tuberculosis, malaria, and HIV/AIDS, and other unallocated means. So in here, you don't see any allocation being toward non-communicable disease, where the majority of mortality will occur, which leads a significant gap in what actually is causing mortality within the population and where programming of the money occurs. So previously, what the two graphs have shown is where mortality is going to occur or is currently occurring within the global population, non-communicable diseases, and where the allocation of global funds is, which is communicable or infectious diseases. So there is a significant gap. Within this gap, governments still have the ultimate responsibility and accountability for their populations. These are governments within low and middle income countries and governments within high income countries. So, within a country's health system, we can think of this as basically three overlapping areas. So, there is public and population health services that has to occur. And then there are personal health service cares, and then there are also health research systems that have to occur to understand sort of where the burden of disease is occurring so they can address those areas. So global, regional, national policies and funding affects local decisions, right? So again, the global decision making is for infectious diseases, which means there's a funding gap for NCDs, which has to occur at the governmental level for low and middle income countries. So there is a significant funding gap. There's an underinvestment at the global level in non communicable diseases. And also, many countries and low and middle income countries take their cues from the World Health Organization in terms of how to make their funding priorities. So many have shifted their funding priorities to infectious diseases and are still slow to make their adjustment to non communicable diseases. But we also know that governments are insufficient, or governments alone are insufficient, and they need to work with multiple actors and stakeholders to really to be able to carry out the needs to address the needs of their population. So when we think about healthcare systems, the World Health Organization has developed a framework which they call a building blocks of health systems framework of how you develop actually um, equitable, sustainable health frameworks, healthcare frameworks. And in fact, healthcare financing is a very important part of this particular framework. At the top is, of course, leadership and governance in terms of building healthcare systems within low and middle income countries. Next is how you really support that system, which is healthcare financing. Third is, of course, health workforce. You have to have a good, solid workforce, and they have to be trained. Next is, of course, medical products and technologies. And then you need information and research. The information provides you the importance, and the research, again, allows you to refine that information, which, of course, feeds into service delivery. Of course, this has to match up with your goals. Your goals is, of course, to improve health quality, and, of course, to provide equity in terms of level, and then, of course, be responsive to the needs of the population. Hopefully, there should be some financial risk protection in which um, the individuals who seek healthcare access will not be financially damaged or be financially strained by accessing the healthcare system. And then through research, you can have improved efficiency in terms of that healthcare system. Moving from the WHO framework of building a healthcare system, essentially, public health systems and healthcare systems must be able to have three main functions. They must be able to assess, which is monitor health of the population, diagnose and investigate. And then they must also be able to develop policy. They must inform and educate the population, mobilize community partnerships, in fact, and then utilize that to develop policies And last is assurance. They must enforce laws, be able to link individuals to care, assure a competent workforce, and then evaluate in that capacity. The WHO Constitution articulates that health is not just the absence of disease, but health requires significantly other things. And in fact, it is a health in all policies that we discussed in Health and Human Rights that has been articulated and has been expanded on. And a health in all policies approach requires several things. First, it requires that the health and well being of all citizens is essential to the overall social and economic development. It also requires that health is an outcome of a wide range of factors which are sometimes outside the purview of the health sectors. And it also has to require an understanding that government policies have an impact, either positive or negative, on the determinants of health. And the impact of the health determinants are not equally distributed among population groups. And in fact, health disparities must be addressed. And in fact, in the US, we can recognize that health disparities exist, and COVID 19 was a prime example of a specific disease that highlighted the significant health disparities that continue to exist within the US among certain populations. And the efforts to improve the health of the populations require collaborative government agency and private sector to develop integrated solutions. And many or most of the pressing health issues require long-term budgetary commitments and creative financing or funding approaches. So an example of a health in all policies approach is displayed on the right-hand side versus a medical models approach. So for example, a medical models approach on the left-hand side equals health system strengthening, which would require healthcare workforce, essential medicines, and universal coverage. This has been advocated by, for example, the UN, the World Health Organizations, and many other organizations, international organizations, and many national organizations. Whereas many people are now moving toward a more health in all policies model or cross sectorial model. Now, this model encompasses urban planning, which thinks about neighborhood and thinks about where things are placed in the geophysical space, thinks about transportation, thinks about housing, for example, making sure that housing is important. For example, homelessness is a significant barrier to health. If individuals do not have homes, it's hard for them to adhere to medication treatment. Homelessness is also a significant barrier for mental health and staying in mental health care. And in fact, socioeconomic status factors, including education, economic development, and many issues, are also factors in terms of health. So this multi-sectorial model has gained significant traction in many fields, and in terms of more progressive thinking in terms of how we start to address issues of health. Here are 5 examples of countries that have partnered with various non-governmental organizations to obtain funding to initiate various programs that have been implemented to solve various issues that have resulted in significant impact. All of these 3 countries have initiated different programs via different financing models and schemes that have resulted and problems that they have encountered that has improved their health care system. I'm not going to go through each of those specific models, but I'm going to just allow you to review all of these three or all of these different examples. Now, there are several other countries that are not on this list that have undertaken similar transformative events within their countries using similar strategies. Country level financing to achieve certain outcomes can be significantly powerful. In terms of what we've discussed very abstract terms. But what I'm going to show is, in fact, four partners working together to achieve outcomes in Bangladesh, specifically for a program, the government's program for Secondary Urban Primary Care Project, or UPHCP2. This is basically four entities: the Asian Development Bank, DFID, which is the Department for International Development, which is supported by the UK government, SIDA, which is the Swedish International Development Cooperation Agency, and the UN Population Fund, all working together to support this program. So this can show you what partners working together to support a government's aims can show in achieving impact for women.
Waiting stoically for their turn. This clinic in a poor suburb of Dhaka sees up to 80 patients a day. Without the services provided here, most of these women would go through pregnancy and give birth at home without professional help. A risky practice with potentially tragic consequences.
5টা বেবি ডেলিভারি করেছে, তার থেকে 3টা বেবি মারা গেছে, স্টিলবর্ন হয়েছে, মরে গেছে, বা এটা মেন্টালি রিটার্ডেড বেবি, লট বেবি থাকে। তো এখন তো সেই রেটটা কম। তারপরে হচ্ছে যে আমাদের গাইনি প্রবলেমের অনেক কমে গেছে, তারা হেলথ কনশাস হচ্ছে, তারা ফ্যামিলি প্ল্যানিংয়ের জন্য আসছে।
The clinic is part of the government-led Second Urban Primary Healthcare Project, financed by the Asian Development Bank with support from the Swedish and British development agencies and the United Nations Population Fund. The aim is to improve the health and well-being of underprivileged women living in Bangladesh's towns and cities. People like Reena Akhtar. She is pregnant with her second child. She lost her first baby soon after giving birth at home. But this time, help is at hand. The project deliberately targets the poorest in society. Those who cannot afford to pay get their treatment for free. Others are charged a subsidized rate. And it's not just obstetrics and gynecology on offer here. There is also information about nutrition, breastfeeding, contraception, sexually transmitted diseases, and HIV/AIDS, allowing women a degree of control over their lives that was previously beyond their reach. The Second Urban Primary Healthcare Project is working to build a pool of knowledge within communities and offer preventative care alongside treatment.
আমি অনেক ভালো ভালো জায়গা চেষ্টা করেছি যে ভালোটা কাউকে দেখাবো। তো পিজি হাসপাতালে, তারপর পপুলার দেখিয়েছি, তো তাদের আন্তরিকতা আমি অতটা পাইনি।
The hope is that the project sets an example of best practice that can be replicated across Bangladesh's rapidly growing urban populations. The benefits are clear. Healthier women are able to be more productive. Healthy children perform better at school, securing a better future for themselves and society as a whole. Investing in the health and well-being of women is paying dividends, a success that is evident on the faces of new mothers across Bangladesh.